Welcome, everybody, to Neuro Wellness Talks in November. Tonight, we're going to be discussing walking difficulties, foot drop, and explore some treatment options. My name is Catherine Kiefer. I am a neuroscience program manager at Rush University Medical Center, as well as the co-founder and president of the Brain Health Center of the Rockies, a nonprofit organization, and patient education manager for Nera Medical. For those of you who are new to Neuro Wellness Talks, this is a webinar series dedicated to empowering patients and your loved ones with practical strategies to support brain and neurological health. Each session will feature experts in neurology, bring in experts to discuss things like rehabilitation, nutrition, exercise, mental health, and highlight evidence-based approaches to living well with MS and other neurological conditions. Our aim is to bridge science and daily life, helping you better understand your condition, make informed choices, and adopt healthy habits for long-term wellness. I am hoping that these sessions will be interactive with opportunities for you to ask questions and share experiences. So I welcome you to use the chat box at the bottom of your screen to post any comments or questions that you have. We will allow time to answer as many of those questions as possible within this 1 hour time frame that we have for this webinar tonight. Tonight we're going to hear from two experts with neurological explanation for walking difficulties such as foot drop and multiple sclerosis. We will dive into a discussion on treatment options such as prosthetics, orthotics, electrical stimulation, physical therapy, and fall prevention strategies. Our two speakers for this evening, we have Dr. Dinesh Sivakalundu. He is a board-certified neurologist and fellowship-trained neuroimmunologist specializing in multiple sclerosis and other complex autoimmune and inflammatory disorders. He is currently seeing patients at the MS and Neuromuscular Center of Excellence in Tampa, Florida. He completed his neurology residency at Yale University School of Medicine, followed by a fellowship training in neuroimmunology and neuroinflammation at Weill Cornell Medicine. His research focuses on how the brain's blood vessels, lymphatic system, and immune pathways contribute to symptoms such as fatigue, cognitive decline, and disease progression in multiple sclerosis. He continues to publish widely in top-tier journals and has earned national recognition and awards. Clinically, Dr. Sivakalundu possesses specialized expertise in advanced neuroimaging interpretation, lumbar punctures, spasticity management, and headache treatment. Outside of medicine, he is a table tennis athlete, which I love, enjoys playing the piano, coding, and spending time with his wife and dog. Our other speaker for this evening is Michael Elson. He is an ABC certified prosthetist, orthotist, and an area clinic manager for Hanger Clinic in Chicago, Illinois. I'm fortunate enough that we have brought in Mike for other patient programs and happy to have him back for this particular session. As an area clinic manager with more than 10 years of experience in the field, Michael specializes in lower extremity prosthetics with a strong interest in microprocessor technology, adult stroke, neuromuscular disorders, Charcot-Marie Tooth disease, ALS, spina bifida, spinal cord injury, post-polio, pediatric cerebral palsy, toe walking, and scoliosis. He finds orthotics and prosthetics to be a perfect combination of medicine, engineering, and working with his hands while providing services that help people in need. He enjoys furthering the field through education of patients, colleagues, and surrounding medical community. Outside of work, Mike enjoys spending time with his wife and his two lovely children. I do want to highlight the fact that we have folks joining us from across the country, from coast to coast, and that this is in particular a program for some of our private practices, such as Advanced Neurology of Colorado in Fort Collins, the Rocky Mountain MS Center in Salt Lake City, Utah, the MS and Neuromuscular Center of Excellence in Tampa, and also practice in Austin, Texas. So on that note, I would like to turn things over to Dr. Siva Kalundo to explain to us a little bit as to what is happening with walking difficulties and foot drop in particular in MS patients. Dr. Siva Kalundo, the floor is yours.
Great. Yeah, thank you so much for the introduction, Kathy, and thank you so much for having me here. So hi, everybody. I'm Dinesh Sivakolandu. I'm a neuroimmunologist and currently at the MS and Neuromuscular Center of Excellence in Tampa. And so, let's see, can everyone see my screen? Great. All right, so I'm going to be talking about the neurologic basis of foot drop and how it happens in MS, and I'll briefly touch upon the treatment strategies, and then I will transition. Then I will hand it over to Mike, who will be talking more about the treatment strategies for foot drop. So before we get into it, so what is foot drop? So it is difficulty lifting the front part of the foot. As you can see in the pictures here, so the patient is trying to lift their foot, and when they're trying to lift their foot, you can see they can lift one of the foot here, and the other foot is they're not able to lift it. And that is called a foot drop. And foot drop is commonly seen in MS, stroke, and multiple peripheral neuropathies. So why is this important? I do have a video here. Let's see if I can get it to play. Just takes a second. Yeah, so this is a patient with foot drop, and you can see as they're walking, it's more clear this section of the video. So they have a foot drop of the right leg. You can see as they're walking, they are dragging their right foot. And as you can imagine, when one patient has a foot drop and when they're walking and they're dragging their right foot, it creates an incredible fall risk, which is definitely not good, and also makes ambulation extremely difficult. So it is extremely important that we recognize foot drop and we treat it appropriately. So before we get into how MS could cause foot drop, let's talk about the normal walking mechanisms. In the picture on the left, you have the brain, and then you have the spinal cord. So the nerves from the brain, so when one thinks about moving any muscle, what happens is there's activity in the brain, and from the brain, the activity goes down the spinal cord, and then there are nerves that exit from the spinal cord, and then they go to the muscle. So when one thinks about moving any part of the body, the activity moves from the brain to the spinal cord and then comes out to the peripheral nerve and then goes to the muscle, causing it to contract. And so the brain and the spinal cord is called the upper motor neuron. And once the nerve exits the spinal cord, and then as it goes out, it is called the lower motor neuron. To get a little more in depth, in this figure, you have the brain, and then you have the nerves that go from the brain. They go down to the brain stem, which is the middle of the brain and the lower part of the brain. And then right before it enters the spinal cord, the fibers cross. And then they cross, go down the spinal cord, and then they exit the spinal cord. And it's for this reason, when you have a lesion or an injury to one side of the brain, the opposite side is affected. So if you have a lesion on the right side, it affects the left side. And then the nerves come out of the spinal cord, and then they innervate pretty much all the muscles in our body. But the muscles that are important for today's talk are the three muscles that are highlighted here that is situated in the front part of the leg. And these muscles, when they contract, they pull or they lift the foot upwards. So just lifting these three muscles, just when these three muscles contract, the foot moves upwards, and just contraction of these three muscles are not sufficient for a patient to be able to lift their foot upwards. Because in any muscle group, there are agonist and there are antagonist muscle. And as you can see in the picture here, there are muscles in the front part of the leg and there are muscles at the back part of the leg. And when the muscles in the front part of the leg contracts, um, it it um, it makes the foot move upwards. When the muscles at the lower part, in the back part of the leg contracts, it pushes the foot to go downwards. And as you can imagine, when when one wants to lift the leg up and lift the foot upwards, this muscle needs to contract and this muscle needs to relax. And if there's a problem in either of these mechanisms, if this muscle is not contracting enough or if this muscle is weak, you could develop a foot drop. Or if this muscle is over contracting or hyperactive, even then you could have foot drop. So what are all the possible mechanisms by which you could have foot drop? So if you have lesion anywhere in the upper motor neuron, what I call the corticospinal tract, this is the tract that runs from the brain all the way to the spinal cord. If you have lesions in the brain or the brain stem or the spinal cord, you could have a foot drop. Or if you have lesion in the nerve that after it exits the spinal cord and that supplies these three muscles, you could also have a foot drop. Or that is, if you have a lesion in the peripheral nerve, or the nerves go in and get into a group of nerves called the plexus. If you have a lesion in the lumbar plexus, or if you injure your peripheral nerve itself, you could have a foot drop. Or if you injure the muscle itself, you could also have a foot drop. We kind of briefly touched upon this. You could have foot drop if there's weakness in the muscle. That if you have weakness of the muscle when its major function is to lift the foot upwards, or if you have increased activity of the muscle that has to relax when you want to lift the foot upwards, even then you could have foot drop. So the increased activity is called spasticity. So if there's spasticity of the muscles in your back part of your leg, then it sort of pushes the foot downwards and one might have difficulty lifting the foot upwards. Any questions so far?
No, we haven't received any questions as of yet, Dr. Sivakalondo.
Okay, great. Yeah, so feel free to ask any questions if anything comes up. We can make this session as interactive as possible. So how MS affects this pathway? So as we probably know, MS is an autoimmune disease that affects the brain and the spinal cord. It predominantly affects the myelin. So in the picture here, so this is a healthy neuron and you have axon going down and you have covering of the axons are called myelin. And the role of the myelin is to prevent leakage of the electrical signals that go from the axon down, from the neuron down the axon. When there is autoimmune destruction of the myelin, then the electrical signal, when it travels down the axon, can leak. Then that can result in slowed conduction, resulting in symptoms. And when the inflammation is severe, you could also have axonal resection. So then the symptoms get even severe. MS predominantly, we still don't know precisely when the onset of MS is. We hypothesize that it often starts as early as first decade of life. It affects women more than men. Um, Several years ago, we thought MS as discrete subtypes, as relapsing remitting MS, secondary progressive, and primary progressive. A lot of patients in my clinic often ask me, hey, what stage do I belong to? As a field in general, we are trying to shy away from those terms. The way we think about MS now is it comes as a package essentially. So you have the inflammatory phenotype and you have the neurodegenerative phenotype. So inflammatory phenotype is when your immune system is causing damage to your brain and your spinal cord. And then when there's inflammation, you have these lesions, and then most of the time the symptoms resolve completely or partially. Um, and then um, and then for a period of time they have very minimal inflammation, and then again they have another relapse, another bout of inflammation. And when one has multiple inflammation at a point it switches to more of a neurodegenerative phenotype, which essentially is just shrinkage of the brain and the spinal cord. Um, we still don't understand entirely what the mechanism of neurodegeneration or progression is, but we do know the relapses pretty much come from inflammation or the immune system causing damage to your brain and spinal cord. Most treatment or therapies that are currently available target this part of the disease, the inflammatory part of the disease, and the goal is earlier we shut down the inflammation, the goal is to maintain the patients at this stage essentially and not go up the ladder like this. So this is an MRI of a patient with MS. Oops, I'm gonna play this. And this is a video of the MRI of a patient with MS, and this is a lesion. And you can see this lesion is caused by inflammation of the immune. It's caused by the immune system attacking the brain and spinal cord. And when one has lesions or inflammation along the tract that is responsible for lifting the foot upwards, one could develop foot drop. So if one has white matter inflammation anywhere along the corticospinal tract, could be in the brain or in the spinal cord, then that could result in foot drop. Another way by which MS patients could develop foot drop is by disease progression. So disease progression is essentially progressive neurodegeneration or progressive shrinkage of the brain and the spinal cord. And if the regions around the area responsible for lifting the foot upward shrinks, then a patient could also develop foot drop. So
So
those
Dr.
two are
Su,
the, yeah.
sorry if I could pause you for just a second there, Dr. Sivakalondo. There were a few questions that have come into the Q&A box. And one has to do with does neurodegenerative types start with an inflammation? If you could maybe talk a little bit about that.
Yeah, most commonly, yes. It often starts as an inflammatory phenotype, and we do know as one accumulates more and more inflammation or more and more lesions, and over it is essentially over, and then over time it switches to a more of a progressive phenotype. In a select few, in less than 5%, it could begin as a progressive phenotype, and in earlier days it was called the primary progressive MS, where they start to progress from the get-go. But then in a majority, it starts as an inflammatory phenotype, and it stays that way for several years before one could transition to a more of a neurodegenerative phenotype.
Excellent. Thank you. And then another question that came through is why does foot drop come and go kind of intermittently?
That's a great question, and I'm going to get to that in a little bit.
Okay, perfect.
And any other questions? So that's about it for now, Kathy.
Yeah, we did have one more, but the question was, have they found any ways to strengthen the myelin sheath that you're aware of?
Not yet. So there have been remyelinating trials. So there have been compounds looking to see if we could remyelinate the damaged myelin sheath. Unfortunately, those trials did not reach their primary end goal, endpoint. But and they think it's primarily due to the heterogeneity of the disease, and there are a lot of work looking at remyelinating agents, but we don't have any successful therapies as of yet.
Fantastic.
Great.
And can you always see the lesions and do they go away if the symptoms get better?
So lesions are essentially scar tissues in the brain. So once we see the lesions, they usually do not. In extremely rare circumstances, they could reduce in size slightly, but then more commonly it just stays. They have in the spinal cord, it's a different story. Sometimes lesions in the spinal cord tend to disappear, but we do think it might be due to differences in the imaging techniques because imaging of the spinal cord is not as mature enough as that of the brain. So we think we're just not capturing all the lesions in the spinal cord.
Yeah, yeah. Fantastic. Well, I'll let you continue. And then there's one that actually a comment around electrotherapy. So that will go to Mike later on.
Okay.
Thank you.
So the two major ways by which MS patients could develop foot drop is by either an inflammatory lesion or through disease progression. And now this is a great segue because we did have a question why sometimes the foot drop comes and goes in MS patients. Um, uh, in the brain, so the brain is extremely flexible, or we call it neuroplasticity. When one develops a lesion, brain can actually compensate, and they can overcome the deficit. But then when there are other symptoms in MS that could transiently worsen the existing symptoms. For instance, MS sensory changes are also common in MS when patients can feel or when they can't tell where the foot is, then it makes it even harder for them to walk. Sometimes fatigue can worsen the gait and foot drop. So that's one of the reasons why one could have fluctuating foot drop. As they're more fatigued, the foot drop could become more pronounced. And then gait can also worsen with heat. We did talk about the mechanism as to why myelin damage becomes important in MS, because when there's damage myelin, then electrical conduction is weaker because the potential action potential leaks, and then there's slowed conduction. So with heat, it taxes the system even more. So gait might transiently worsen during heat as well.
And what
So
about
when I
cold?
say,
So I'm so sorry, Dr. Sivakalundu, but there was a question that came through in the chat box. I was wondering, could cold also impact the foot drop, or is it primarily just with heat?
So theoretically, cold should not affect it, but I have seen a few patients in the clinic where they do comment on cold, not cold actually making it worse. So we still don't know the mechanism as to why cold might affect the foot drop, but theoretically, just understanding the mechanism of axonal conduction, heat worsens the symptoms in MS, and it is a well-described phenomena. It's called the Uthoff's phenomena.
Thank
Yeah.
you.
So when I see a patient with foot drop, what goes on in my mind? So the first thing I want to do is I want to confirm if the patient has foot drop. And once I confirm the foot drop, then I want to see if it is due to weakness of the muscle or if it's due to increased tone of the muscle causing foot drop. And I also observe for gait patterns, whether they're dragging the foot or any steppage pattern. Excuse me. And once I confirm the foot drop on examination, next I want to determine the level of lesion. So I want to see if it is from the brain or spinal cord or if it is from the peripheral nerves. And I do that by a clinical examination. And once I'm able to localize the lesion, and if I think it's from the brain or spinal cord, then I get the MRI of the brain, cervical spine, and the thoracic spine. If it is from the peripheral nerves, then I would get a nerve conduction study to further localize where it is in the peripheral nervous system. And we might also order an MRI lumbar spine. And since we are talking about foot drop in the context of MS, let's say if the lesion localizes to the central nervous system, it could be from an active inflammation. Then it is often a new deficit from the inflammation causing foot drop. So the treatment goal is to suppress the inflammation and accelerate recovery. So the treatment often involves high dose corticosteroids. Recovery varies. A lot of times, patients recover well if it is due to an acute exacerbation. Sometimes it could be partial or incomplete recovery, depending on the level of axonal damage. And once we have an acute relapse, then we'll start talking about disease after we treat the acute exacerbation, then we will start talking about the disease modifying therapies. And the goal of these therapies is to essentially prevent any exacerbations happening again. And the second way by which MS patients could develop foot drop is by disease progression. It is often characterized as it's gradual and it is irreversible accumulation of disability, and it is independent of inflammation. We spoke about the mechanism earlier on. It's predominantly neurodegeneration or shrinkage of the brain and spinal cord with axonal damage. It often manifests as slow and progressive weakness, and including foot drop. Unfortunately, there are currently no therapies to halt progression. There are numerous clinical trials that are up and coming, so we are confident that in the next few years we might have a therapy for disease progression. Um, the only drug that has shown modest benefit in primary progressive MS is ocrelizumab or Ocrevus, but the benefit is very modest, and it is thought to provide that benefit by primarily suppressing the peripheral immune system. Um, so the benefit is highly debated in the field, because when we remove the effect of inflammation, then the benefit sort of reduces. Um, so although it is approved for primary progressive MS, when it comes to disease progression, it is often a discussion with the patient and how they might respond. The main therapy at this point when there's disease progression is going to be supportive management with physical therapy, orthotics, and assistive devices. And Mike is going to talk a lot more in depth about it. But that is extremely crucial. I can't emphasize how important that is, because we know that there isn't a great therapy to halt the progression, but understanding that we want to provide the best functional outcome for patients. So they're able to walk comfortably, they're able to walk safely. So it is predominantly used in patients with partial or incomplete recovery, often acute relapse, or with progressive forms of MS. And so the management strategies mainly include physical therapy. Mike is going to talk a lot more about it, which includes just exercises, braces, or gait assistive devices, also involve like stimulating the muscles that are weak. In the clinic that we do, or spasticity management, when the muscles are hyperactive, then we could relax the muscle with a medication, or we could give Botox injections to reduce the muscle overactivity. So the key takeaway, foot drop in MS can happen either from active inflammation or from disease progression, but we have to always keep in mind that it could also be non-MS causes, peripheral neuropathy or lumbar issues. So we want to make sure that we want to figure out why the foot drop is happening before we treat it. Other MS symptoms, such as fatigue and altered sensation, can worsen or exacerbate the symptoms from foot drop, such as walking difficulties. So, early recognition, rehabilitation, and really multidisciplinary care are extremely important to achieve the best functional outcome and improve quality of life. So that's all I have for today, and I'm happy to take any questions. And if not, I'll hand over the stage to Mike.
Oh, fantastic, Dr. Sivakulundu. Um, some of these questions are going to be more targeted for Mike, but there was a question: if someone falls a lot due to foot drop and they do wear a brace, what else potentially could be causing that falling to happen?
Yeah, that's a great question. So falls can be, of course, from foot drop. And second, we also want to look into balance issues. So a lot of times, because MS affects the brain and the spinal cord, and if it affects the back part of the brain called the cerebellum, balance could be off as well, and that could also be contributing to falls. And another reason is sensory disturbances. If you're not able to feel where your foot is at, then in addition to having a foot drop, when two factors compound, that could also contribute to fall risk. So really, then at that point, we need to figure out why you're falling and provide assistive devices so that we can tease apart each mechanism and address it independently. In that way, we can reduce your fall risk.
Fantastic. Yeah, thank you. There was a question, and I think you addressed it previously, as to whether or not there's anything to help reduce the brain and spinal cord shrinkage. And I know you touched upon DMTs. Any other comments that you can make there?
Yeah, I mean, so with DMTs, it primarily targets the inflammation. There is Ocrevus that is approved, but with just modest effects. There are numerous therapies that are in clinical trials. We are hopeful that there are multiple readouts that are up and coming, so exciting times ahead, definitely for sure. But as far as other things, what one could do to reduce brain atrophy and spinal cord atrophy is so I call it the four pillars of MS. One is exercise. I can't emphasize how important exercise is. Because it's also building resilience and building strength to overcome the disease progression that is happening. So exercise is extremely important. Second is healthy diet. So diet rich in vegetables and low processed food often helps. Third, is social and good mental health to make sure that their social health is good and their mental health is good as well, because all of that could compound in addition to disease progression. And then other things to keep in mind: smoking can accelerate progression. So cigarettes can be or tobacco use can be harmful in that scenario. Yeah, so those are the main things what I would say that one could do to halt progression, at least as of now.
Yeah, that's beautiful. You're speaking my language. Those are the pillars of brain health. So fantastic. Um, there are two other questions, and maybe we can address them quickly because I also want to make sure that we get to Mike's presentation. So if somebody's been working out and exercising and needs to sit and rest to eliminate the foot drop, what else could help alleviate this issue? Is there any other recommendations that you could potentially make?
I'll defer that to Mike. I think he might be able to talk more about it.
Perfect. And then
Yeah.
last question is, are there any tests that determine if foot drop is due to hyper active nerves or weak muscles? It's actually a
Yeah,
great
so
question.
yeah, that's a great question, and we can assess that in the clinic. And that's what I test for all my patients with foot drop, because it can be either due to spasticity or due to weakness. Yeah, so I would talk to your clinician, and they should be able to test it in the clinic.
Beautiful. Well, I appreciate it, Dr. Sivakalundu. Thank you so much.
Yeah,
Mike, at
thank you.
this point, I think we're good to turn it on over to you to talk about treatments.
Perfect. Thank you. Let me share my screen here. Right. Can everyone see my presentation here?
Sure can, yeah.
Okay, perfect. Well, my name is Mike. I'm a certified prosthetist orthotist with Hanger here in Chicago. Let me see if I can scoot forward here. Did it switch to the next slide here?
Switch to the next slide. You might want to put it on presentation mode.
Okay, there we go. How are we now?
Yep, we just have your next slides that come up with it. There you go.
All right, perfect.
Fantastic.
All right. So about me, I'm from Oak Park. That's here in Chicago. I went to University of Illinois in Champaign. I was an engineer. I studied material science engineering, and I worked as an engineer for a little bit, but I didn't really like it. So I knew of the field of orthotics and prosthetics. My little brother had braces growing up. So I shadowed at a local office here in Chicago, and I liked it. And I went back to school at Northwestern, and did my residency with a company called Check and Cyrus. And I've been here at Rush for about 12 years now. So I'm a clinician. I see patients. I manage the office, and I'm also an area manager as well. And Kathy, I guess I have to update you. I have 3 kids now.
Oh,
So family's growing.
lovely. Congrats, Mike.
So what is a CPO? No, who am I? This is a hard words to say, certified orthotist, prosthetist. So orthotist is the orthotics, the bracing, and prosthetist is when I'm designing artificial limbs for amputees. So a CPO, our degree, it's a pretty small field. There's about 13 schools across the country. Nowadays, it's a 2-year master's program, followed by 18 to 24-month residency, and then you sit for your boards. So just to know how small our program is, or my field is, my certification number in the entire US over the last 100 years is 3,485. So that just shows you there's not that many CPOs in the world. So as Dr. Siva was talking about, foot drop, when does it happen? When does it occur? This is the gait cycle, right? So as we're taking a step, the first time you might notice a foot drop is when you plant your foot, your heel on the ground. We use those dorsiflexor muscles, those muscles in the front, to slowly lower our foot to the ground. So some people who have a foot drop, they might actually start to notice it as what's called a foot slap. So as they're putting their foot to the ground, it goes ahead and it slaps, and you're not able to control that foot coming to the ground. And when you're walking around, people will be able to hear you. Okay, so sometimes as I'm teaching residents that come through my office, I'll tell them, pay attention to as these patients are walking into the room. Sometimes you can already hear them walking. Sometimes you can already hear that foot slap. And then you can ask them, oh, okay, are you tripping? Are you falling? Because that might be a key that they might have a foot drop. As you transfer over into the swing phase, that's when that foot drop can cause a fall. And oftentimes patients will catch their toes and trip and fall. And the body's we're pretty resilient, right? We do a lot of things, we compensate so that we can keep walking and so that we're not going to fall. The body does things to try and allow us to keep walking without falling. So you might notice you might do something called a high steppage gait. That's something that Dr. Siva talked about. Basically, you lift up high at your hip to kind of walk over your foot so you're not going to catch your foot. Another thing, another compensatory movement is what's called circumduction, where you're actually kicking your leg out to the side so you're not gonna catch your foot. And then there's two other ones that are a little harder to catch. It's called vaulting and hip hiking. But those are most of the compensatory things that patients do so that they're not gonna fall and trip. So when patients come in and talk to me, what are some of the things that they say? They say, "Hey, Mike, I'm just noticing some minor tripping," right? But minor tripping can lead into a big fall. Or, sometimes it's more difficult for me to walk and my back starts to hurt. Or like I said, everyone's always hears me walking. Maybe I have that foot slap, right? Maybe it's the beginning of my dorsiflexion weakness. Or they'll say, "I only fall once a week," right? We don't want you falling at all, right? One fall can lead to, a hip fracture in the hospital, and we don't want anything like that. Or they just say, "I do a good job compensating." Sure, you probably do, but we can try and improve your gait with physical therapy and also potentially orthotics. So what are our goals when it comes to orthotics? We want to get you up and moving, right? We want to keep you moving safely. We want to prevent those falls from happening. Even if you haven't fallen, if you've had some trips, we want to lift up that foot so that you can keep being ambulatory. Oftentimes I'll ask patients, you might be fine walking inside your house. It's a familiar environment. You don't have any trips or falls, but when you're walking outside and there's that crack on the sidewalk, do you sometimes catch your foot then? Or do you go to someone's house, a friend's house, and they have a shaggy carpet and you catch your foot then? Those are the times you want to be paying attention. And then oftentimes a lot of my MS patients, when they have a foot drop, they're always looking down at the ground, right? They're always looking to make sure they're not going to catch their foot on something instead of opening up and looking at their surroundings. So another goal, enhance those gait mechanics, enhance that confidence by improving your ambulation, allow you to be confident getting out there walking, and then also reducing your joint overuse and pain. If you have that high steppage gait, you're constantly using your hip, flexing at your hip, over flexing at your hip so that you're not going to catch your toes. And then that can lead to overuse of your hip. And then also, oftentimes, a lot of people have back pain as well. So when a patient comes in to see me, they've already come in. They typically have seen their neurologist. The neurologist said, "Hey, you have a foot drop. Here's a prescription. It says AFO, foot drop, MS. Go see an orthotist." When a patient's come in to see me, I do a manual muscle test, range of motion. I watch them walk. And then I start asking them questions. Are you tripping? Are you falling? Are you using a cane? Are you using a walker? Have you done physical therapy lately? Super important that patients continuously do physical therapy. Even after they get their, if they get an orthotic, it's important that they get physical therapy after they get an orthotic so they can learn how to use it properly and improve their gait mechanics. What are your hobbies? Are you noticing that you just have a foot drop later in the day? Sometimes when I'm seeing patients, I'll say, if it's the beginning of the day and you're feeling pretty strong and you're not noticing you're catching your toe, then don't use the brace. The brace, you need to think of the brace kind of as a tool that's going to help lift up that foot when you need it. So sometimes I'll say to patients, it's later in the day, you still got to go to the grocery store. You're fatiguing, like someone else mentioned. Why does sometimes if my foot drop worse than other times? Maybe you're fatigued from what you've done for the day. And now you're at a potential where you're going to trip and fall. Put the brace on then. You don't necessarily have to wear it throughout the entire day. You'll kind of notice it as a tool so that you're up and moving and not falling. Heat sensitivity, that's what someone else mentioned. I try and use braces where you're not encompassing the leg as quite as much because I know a lot of my MS patients have heat sensitivities, and I don't want to exacerbate that MS response. So a couple typical questions people ask me, are orthotics, AFOs, are they covered by insurance? Yes, they're typically covered. Insurance wants to get you up and moving. They want you outside. They want you moving safely and not falling and ending up in the hospital. And then another question I typically get is, do orthotics make me weaker? No, they don't really make you weaker. What they're designed to do is help assist you so that you have more normal gait mechanics and you're out there walking more and preventing falls. So as an orthotist, I'm always trying to design something that I know the patient's going to use. Number one, I don't want to get you a brace and it ends up in the closet and you're never going to use it. Number two, it's going to fit appropriately so that you'll actually use it, right? And then that I'm kind of on the cusp of providing you enough support, but I'm not over bracing, where I'm not encouraging you to use all your other muscles that are still strong to continue to strengthen. So what are the different types of AFOs? These are ankle foot orthoses. I oftentimes use what's called a custom fit carbon fiber AFO, custom carbon or module 3D printed AFO, or custom plastic AFOs. Those kind of the three different options. The custom fit carbon AFOs, like this one in the picture and right here, they're lightweight, so that if you have some hip flexion weakness, you're not really increasing the weight down by your foot much. They're very easy to use. They're trimmed to your foot size. They slip inside the shoe. You put the insert back on top, and they're like a big spring that's gonna help lift up the foot. I use this all the time with my MS patients. Fits in most of their shoes. There's different designs. There's different strengths. Some have a medial bar. Some have a lateral bar. I kind of figure out what's going to work best for that patient. And these are very, very successful for the MS patients.
Mike, if somebody has a 3D generated AFO for their ankle, can that be adjusted?
Yeah, for sure. Pretty much all the things that we make, right? We can adjust. We have big machines. We use heat. We can add padding. That's kind of where we really excel as orthotists, is adjusting and designing braces so that they fit appropriately. So if you have a brace and it doesn't fit appropriately, go back to where you got it, reach out to them to let them know, like, hey, this is bothering me in the arch. Can you adjust this? Because we want you to be able to use it. We don't want to be making your brace that you can't use.
Right. And I guess there's no need to replace a brace unless there are actual problems or it's not doing the job that it's intended to, right?
Exactly. And sometimes there is a need. Sometimes I might start off with a patient with one of these flexible custom fit carbon AFOs because they just had like a minor foot drop. But then as their disease progressed, maybe they started getting some more spasticity, or the foot drop became worse, or they started getting some other weakness and they started noticing some buckling. In that case, I would transition to something more of like this, the modular 3D printed AFOs or custom carbon AFO like this one here. Still lightweight because we're using materials that are light, but now you're getting something that's a little more dynamic, something that can provide more stability if you're buckling or you have some knee hyperextension, or you need a little more control side to side. So oftentimes I might progress a patient as they continue to get weaker to something similar to this. And when we're designing these, we're actually taking an actual mold of the patient's limb, or we're actually taking a scan and we're creating the brace from that mold or scan.
And what if the AFO is leaving like pain points on the leg or the foot and ankle? Can that be adjusted as well?
100%. Yep. Some typical areas where you might get skin breakdown would be your ankle bones. Maybe if you have some pressure up near the top of your calf, those are all things where we'll make adjustments, we'll heat, we'll relieve, we'll add padding, because we're trying to provide control, enough control that it's comfortable and we're stabilizing the foot, but there's not too much pressure on certain bony landmarks. So I'll see a patient, I'll evaluate them, I'll take a mold, I'll see them back in a couple of weeks, they'll get the device. I'll try as the orthotist to figure out, all right, I think there's going to be some problem areas here, 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 and I'll adjust it. I'll send the patient home, and then they might come back in like 2 to 3 weeks and say, hey, Mike, I've got a little redness here in this spot. Can you adjust this? So that's very typical.
Perfect. Thank you.
Then the tried and true, that's the custom plastic AFOs. These have been around the longest. They work. I use these when I want to provide the most amount of control for the patients. So take a mold and then we pull a hot piece of plastic over the mold, and then we can play with the different trim lines to figure how much control we want to give towards the patient. So those are the different braces. Like I said, you'll typically have a prescription from the doctor that says AFO. AFOs pretty much always work, but you have to wear them with shoes. So what if you have someone that doesn't want to wear shoes? Maybe they don't want to wear shoes in the house. There's different technologies out there. And one of them is what's called functional electrical stimulation, FES. So I saw in the chat someone said something about this. Basically, it's like a smart TENS unit. A TENS unit, basically what it does is it provides a stimulation through the skin to the muscle to have the muscle contract. And in this case, it's contracting the dorsiflexor muscles to help lift up your foot. And the FES devices, what they do is there's an inclinometer, an accelerometer in the actual device, and it knows where you are in the gait cycle, and it tells that stimulation unit when to turn on and when to turn off. So it's a pretty cool, neat technology that's been growing in the past 10 years or so. They are FDA approved devices. There's not too many of them out there, but there's more and more companies that are trying to develop these. They're not really covered by insurance. Oftentimes our insurance companies follow what Medicare says, and to Medicare, FES devices is experimental. If you have like a workman's comp or VA, they might cover it, but typically it's not covered by insurance, and they're not inexpensive. They're pretty expensive. They're around $3,000 to $6,000 depending on which one you do. So oftentimes I'll see a patient, I'll evaluate them, I'll talk about FES, I'll let them know about how expensive it is and the benefits of it. I'll have them then come back to trial a device and see if it actually works for them. And then I also couple that with a brace because I know an AFO is pretty much always going to work. FES can sometimes be finicky and you got to troubleshoot it a lot. Whereas an AFO, I know when you put it on, it fits, it goes in your shoe, it's always going to work. So FES, it's not an external brace. It's a unit that goes onto your calf muscle, or actually onto your dorsiflexors. Sits right underneath the knee. Some of the benefits, it's stimulating your own muscle, right? So your muscles are contracting. You're not relying on an external brace to lift up your foot. So I have plenty of patients that are maintaining their strength or might even see a little bit of improvement in the strength. Just like Dr. Siwa was talking about, FES, what it's doing is it's actually sending the signal back to the brain. So there is some neuroplasticity effect to FES as well. Because your own muscles are actually contracting, that is helping the fluids get out of the leg, and that can also help with swelling. I've had some patients that have seen some improvement in spasticity, specifically if they have plantar flexion spasticity, because we are stimulating the dorsiflexor muscles, and then automatically those plantar flexion muscles turn off, and some patients see a reduction in spasticity. Another benefit is you don't have to wear shoes. You know, if you want to go walk on the sand, you live in Tampa, Florida, and you want to walk on the sand. Well, if you're wearing an AFO, you always have to wear a shoe with it because otherwise you're going to slip. FES, you're able to walk barefoot, or if you walk barefoot in the house, FES you can use as well. Some of the yeah, go ahead.
Sorry, if somebody would like to test FES, is there like a free trial period that patients have with
Yes. So every company is different. I would recommend reach out to your local orthotist. I work for Hangers across the entire country. Reach out to the local orthotist that your neurologist works with. And oftentimes they'll allow you to come in, they'll trial it. Sometimes they even have a trial unit that you can take home for a month to try out and see how it works before you actually purchase the unit, because it's definitely an investment. So you have to really understand how it works and make sure that you'll actually use it. Some of the contraindications, if you're pregnant, if you have epilepsy, if you have an implant in your leg or pacemaker, if you have any of those things, you have to talk to your neurologist and get it cleared by them to allow the use of the FES. So these are my thoughts on the different FES devices that are out there. I've worked with most of them over the years. Walk Aid, that's one of the older technologies. It's based on using gel electrodes. It doesn't really have an app. And that used to be the only FES device out there. It's pretty finicky at times. So I typically don't use Walk Aid anymore. Bioness is another FES device. They use cloth electrodes, and it's pretty easy to use. Patients can put it on themselves, and it reproduces the same dorsiflexion. Pretty easy. It does have an app as well, and there are 2 channels where you can actually have a thigh section as well. So the 2 units talk to each other, so you can stimulate your quad while you're also stimulating your dorsiflexors. I typically use the Bioness in my clinic here. EvoWalk is a newer technology. They got FDA clearance this year, so you'll see more of these out there. Again, it's a cuff. It runs on an app on your phone. There's 2 channels, so you can really play around with the EvoWalk. You can target different muscle groups. You can target your glutes. You can target your hamstrings, your quads, also while you're targeting your dorsiflexors. So that's a pretty neat device. And then there's also the Cyanic Neural Sleeve. I have not worked with the Cyanic Neural Sleeve. It is the company, you work directly with the company. It's pretty much all remote working with the company. So it'd be interesting to see if anyone on here, you can kind of put in there or shoot me an email what you think about the Cyanic Neural Sleeve. To me, the only thing I'm not so sure about it is it wraps around the leg, which could create some heat sensitivities. So that's my thought on it. The first 3 is something that you purchase the unit. The Cyanic Neural Sleeve, that it is subscription based. So if you're interested in any of them, I would reach out to your local orthotist. If you're interested in the Cyanic Neural Sleeve, I would reach out directly to the company, and you can look on their website and you can see how to get a device from them. That's pretty much ends my talk. Are there any questions out there, Kathy?
Yeah, there sure are. So, questions regarding like rash and when you get swollen. So, is it why would somebody be getting a rash from a brace? What might be going on there?
Yeah, if it's not fitting properly, or it's rubbing too much, sometimes you might have to cut the brace in a certain area. Might need to add a different type of padding in there. Or sometimes it could just be, your sock bunches up in a certain area and it's causing that skin irritation. I typically tell patients to wear a long cotton sock. over their leg and then put the brace on to minimize that friction. And also to allow the skin to breathe so that there's, if we're doing like a full plastic AFO, there's a material in between your skin and that plastic.
And on a similar note, so if somebody gets really swollen after wearing their AFO during the day, what I assume again, there's some abrasion that might be happening that could be leading to that swollenness. Is there any, well, I guess you answered that too. I guess wearing the sock and everything would ultimately help with
But the swelling, you know, typically the swelling isn't actually from wearing the brace. Typically it's from being upright and your muscles are not working as much to help the fluid get out of your leg. But for my patients that do have some fluctuating edema and swelling, I'll typically go with some sort of brace that has minimal contact with their skin, like one of the flexible carbon fiber AFOs that pretty much just touches your calf and then goes into your shoe and doesn't really touch your skin much. That way, no, whether your volume is down or up, you can still use it, and there's minimal skin irritations.
Fantastic. Two more questions, one for you, Mike, and one for Dr. Siva Kolundu. Any comments around red light research and whether or not any of that might help with foot drop?
I'll let Dr. Siva take that one.
Yeah. So it's a lot experimental. There are a lot of companies doing photobiomodulation therapy, red light therapy. They also have near-infrared therapy. So they're all small-scale trials, and the data on that has been mixed. So we still don't know yet. So just future studies need to be done for us to concretely say to what extent it's going to help.
I haven't seen any solid data on that either. And then this would be for you as well, Dr. Sivakalundu. Would foot drop cause glutes to spasm?
Not so it's a really good question. Spasms are very common in MS, because with the autoimmune system affecting the brain and spinal cord, and depending on the regions where the nerves are being, so the regions that the nerve is supplying, when those nerves are, when those representations are injured in the brain and spinal cord, then you could have spasms anywhere in that region. So yeah, so spasms are extremely common in MS. You could get it in your glutes, you could get it in your back, in your legs. Yeah, so most commonly it is independent. So directly not related to foot drop, I would say.
Yeah. Okay. Well, I know we're a few minutes over. I do want to just get one more question answered. Excuse me. Are all the FES external? Is there any that there would be a need for an implant?
Yeah, currently they're all what's called subcutaneous. So they're basically, you wear it on the outside of your skin. There's nothing internal. Basically, the electrical shock goes through your skin, so you can't be wearing lotion on your leg to make sure that there's a good stimulation to that muscle. And I saw here in another chat here, someone said they used Cyonic. It seemed good, but didn't work for me. But I only had to pay for a couple months. Yeah, I would try different things. Try an AFO. AFOs pretty much always work. Try the FES. Maybe use them in tandem. In Cyonic, nice thing about Cyonic, it's subscription based, so you can try it for a couple months, see if it works for you, and then maybe try some of the other FES devices out there.
Fantastic. I have to say this was a really good session. I think a lot of good information that both of you shared with our audience. Thank you so much, Mike, for joining us again. And like I said, I'm probably going to be knocking on your door here in the future again, because it's always good to be able to provide this type of information to patients. And Dr. Sivakalundu, thank you for providing kind of the science behind everything as to what in particular is happening for our multiple sclerosis patient population. The quick shout out to all of the practices that I know are logging in. So Central Texas Neurology Consultants down in Austin, Rocky Mountain MS Clinic in Salt Lake City, Advanced Neurology of Colorado in Fort Collins, Colorado, and MS and Neuromuscular Center of Excellence in Tampa, Florida. Thank you all for such a wonderful evening. I hope everybody has a great night, and we'll see you back in here very soon. Thanks so much.
Thank you.
Thanks.